Okay, so picture this. A tiny, rogue blood clot decides to go on a really dangerous road trip through your body. And its final destination? Your lungs. Now, this isn't some plot from a medical thriller. This is the real story of a pulmonary embolism. It's a condition that can be super tough to spot, but it's absolutely critical to understand. So today, we're going to follow that clot's path and unpack its story from start to finish. So here's the game plan. First up, we're going to figure out exactly what we're dealing with. What is a PE? Then we'll look at the risk factors, the things that make it more likely, and we'll do a special deep dive into pregnancy. After that, it's all about the detective work. How did doctors actually find this thing? Then we'll get into the action, the treatment plan. And finally, we'll look at what happens afterward and how we can stop this whole story from even starting in the first place.
All right, let's start at square one. What exactly are we talking about when we say pulmonary embolism? At its heart, a PE is basically a plumbing problem in your lungs. It's a blockage. But here's the twist. The culprit, this blockage, almost never starts in the lungs. It's usually a piece of a blood clot, what we call a thromboembolism, that forms somewhere totally different. Typically, deep in the veins of your legs or pelvis. And that original clot? That has a name you've probably heard, a deep vein thrombosis, or DVT.
So this clot's journey really happens in 3 stages. First, you've got the formation. The clot, a thrombus, just hangs out in a deep vein. Step 2 is the travel. A piece of that clot breaks off, now it's called an embolus, and it's on the move, cruising through your bloodstream. And finally, stage 3, lodging. It travels all the way up through the heart, and then it gets stuck in the smaller arteries of the lungs. And that's it. That's the dangerous blockage.
But why do these clots even form in the first place? Well, it pretty much always boils down to a classic medical concept called Virchow's triad. Think of it as a criminal trio, a perfect storm of 3 factors. First, you've got blood that's just not moving well. It's slow or stagnant. Second, the blood itself is extra sticky and more prone to clotting. And third, there's some kind of damage to the inside wall of the blood vessel. Get one or more of these guys together and boom, you've got the recipe for a clot.
Okay, so if Virchow's triad is the recipe, who's most likely to have all those ingredients in the mix? Let's get into the risk factors, and we're going to pay special attention to a situation that brings this whole trio together: pregnancy. So here are the usual suspects, and if you look closely, you can see how they all connect back to that criminal trio, right? Major surgery, that causes vessel injury and you're not moving around much. A long flight or bed rest, that's stagnant blood flow. Things like cancer or certain genetic conditions can make your blood hypercoagulable or extra sticky. And of course, having a clot before is a huge red flag for getting another one.
But what about pregnancy? It's a totally natural process, so why does it create this, well, perfect storm for forming a blood clot?
It's kind of wild, actually. Pregnancy literally checks all 3 boxes of Virchow's triad. As the baby grows, the uterus puts pressure on the big veins in the pelvis, which slows down blood flow coming back from the legs. That's box 1. Then, the body cleverly changes its chemistry to prevent too much bleeding during childbirth. It actually makes the blood clot more easily. That's box 2. And finally, the process of delivery itself can cause a bit of injury to those vessel walls. Box 3, the whole trifecta. And the result of all that? Well, the risk of having a PE jumps up by 4 to 5 times during pregnancy. It's a huge increase. And it's exactly why pulmonary embolism is, tragically, one of the leading causes of maternal death in the developed world.
So this brings us to a massive challenge. If we know who's at risk, how in the world do you find the clot? Diagnosing a PE is like a high-stakes detective story, and it gets even trickier during pregnancy. And here it is. This is the absolute heart of the problem. You've got shortness of breath, a fast heart rate, maybe some leg swelling. Is that a deadly PE, or is it just a normal day in the 3rd trimester? The overlap is huge, which makes it incredibly difficult to figure out what's going on based on symptoms alone.
So, to try and cut through that fog of uncertainty, clinicians don't just guess. They use scoring systems like this one, the Simplified Revised Geneva Score. It helps them put a number on their suspicion. It's not going to give you the final answer, but it's a super useful way to decide, okay, how likely is this really, and do we need to move on to some bigger tests?
And for pregnant patients, there's a very clear logical playbook to follow. The goal is to get the answer while using the least amount of radiation possible. So if the leg is swollen or painful, you start there with an ultrasound. If you find a DVT, game over, you treat for a PE. If not, then you move up to the chest, usually starting with a simple X-ray, and that result helps decide which bigger scan comes next.
When it comes to those bigger scans, doctors have to make a choice, and it's a big one. It's a showdown between the CTPA and something called a V/Q scan. The CTPA gives this amazing, direct picture of the arteries, but it does expose the mother's breast tissue to more radiation. The V/Q scan, on the other hand, has super low radiation to the breast, but a tiny bit more to the fetus. The right choice really depends on the situation, but the key takeaway is that both are considered safe to do when they're truly needed.
Okay, so the clot has been found. The detective work is done. Now the fight begins. But here's the thing. The treatment plan isn't a one-size-fits-all approach. It's a strategic response that is tailored very specifically to how much danger the patient is in right at that moment. We basically sort PEs into 3 risk levels. For low risk, the goal is pretty straightforward. Just prevent any more clots from forming. For intermediate risk, that means the heart is starting to feel the pressure, so the main goal is to stop things from getting worse, to prevent a total collapse. But for high-risk PEs, also called massive PEs, that's a whole different ballgame. The patient's blood pressure is dropping, the heart is failing. The goal here is simple and urgent. Restore that blood flow and do it immediately.
Now, no matter the risk level, the foundation of treatment is always anticoagulation. You've probably heard these called blood thinners, like heparin. Here's a really important point, though. They don't actually dissolve the clot that's already there. What they do is prevent new clots from forming and stop the current one from getting any bigger. This gives your body's own natural systems the time they need to break down the existing clot. But when the situation is life or death, you have to bring out the big guns. This is where we use thrombolytics, which we call clot busters. Unlike blood thinners, these powerful drugs do actively dissolve the clot to open up that blocked artery. In some really critical cases, surgeons might even go in and physically remove the clot, or a specialist can thread a catheter right up to the clot and deliver that medicine directly to the source.
Now, of course, when a patient is pregnant, the entire playbook changes, because you're always treating 2 people. The go-to drug is low molecular weight heparin, or LMWH, for one simple reason. Its molecules are too big to cross the placenta and affect the baby. Other common blood thinners like warfarin are an absolute no-go. And those super powerful clot busters, they're used only as an absolute last resort when the mother's life is hanging in the balance. So what happens after the immediate danger is over? Surviving a PE is a huge deal, but it's often just the first step. Let's talk about the long-term consequences and maybe most importantly, how to prevent this from happening again. Yeah, the journey doesn't always end when the patient leaves the hospital. A lot of survivors deal with something called post-PE syndrome, or they have lasting shortness of breath and just can't do what they used to. And sometimes the clot doesn't fully dissolve. It can turn into scar tissue, which leads to a really serious condition called CTEPH. It's like that temporary clog in the plumbing becomes a permanent one, causing constant, dangerously high blood pressure inside the lungs.
And this isn't some super rare thing. We're talking about 1 to 4% of all PE survivors who will go on to develop CTEPH. It might sound like a small number, but when you think about how many people have a PE every year, it's a really significant problem. It just hammers home how important that long-term follow-up really is.
And that brings us to the big final question. We've gotten so much better at finding and fighting these clots once they show up. But the ultimate win, right? The ultimate goal is to stop them from ever starting that journey in the first place. So the question we have to ask ourselves is, how can we get better at protecting people before that clot even has a chance to form? How do we shift from being reactive to being truly preventative?